some degree of survival of the fittest. And an evolutionary view implies how something adapts to a changing environment. And that's really going to be the theme that ties together the talks that I've been giving over the past year. Now, if I'm going to start with by the way, was anybody here at my talk at HIMSS this year? Well, Charles, you don't count, so you invited me. So that's good. Okay, so there's a lot of new content here that wasn't part of that talk. But if I'm going to start with an evolutionary perspective, I've got to give the correct political balance. And so we're going to start with a biblical beginning. In the beginning. In the beginning, a physician created the paper chart. And the chart was out form and illegible. And darkness was on the face of the hospital. And the director of HIMSS said, "Let there be order." And order was created in the midst of chaos. And the director divided the chart into sections and saw that it was good. And the director said, "Let there be progress notes and order forms and all manner of such documents." And the forms committee created those. And they went forth one by one and two by two into the chart. And it was so. And the HIMSS staff gave names and purpose to the documents and counted their comings and goings, but was unable to read them. And so on the seventh day, a symposium was held on the illegible medical record. But on the seventh day, the physician rested and played golf. So the medical record. Onto the body of the talk. In 1831, a 20-year-old Charles Darwin joined the HMS Beagle for what came to be known as the second voyage of the Beagle, which was, as you all know at this point, to the Galapagos Islands. Along for the ride as a cabin boy on that trip was Simms Covington. Simms Covington is probably somebody you don't know. He was a cabin boy and a fiddler and ended up being an assistant to Charles Darwin for a number of years. His role on the voyage once he became an assistant to Darwin was to help him collect specimens, whether these were fossils, plants, animals. He provided taxidermy services, and he worked with Darwin after the voyage ended. While Darwin was busy looking at the geology of the island, one of the roles that Simms Covington was given was to collect birds, shoot the birds and collect them. There's actually a book that's called Darwin's Shooter. The birds he collected were finches. Those finches have become famously known as Darwin's Finches. Darwin's finches were presented to the London Geological Society in 1837, 2 years before publication of the Voyage of the Beagle and 22 years before he published Origin of the Species. What was so important about these birds that they became known and remain a famous example of evolution? Based on a number of factors, these birds all appeared to have come from a single ancestor. Yet, depending on which island the bird came from, the beaks seem to have adapted to fit the food supply, whether they were insect or vegetable, etc. This observation was key and has become a hallmark example of something called adaptive radiation. Adaptive radiation refers to the evolution of diversity in a rapidly multiplying lineage of animal from a single ancestor, the idea being that the various birds all came from a single ancestor, but over time the beaks evolved to allow them to take advantage of the resources of the island on which they found themselves. This is a little faint, but even in Origin of the Species, you can see and I'm going to hope that this is the pointer, yeah, the kind of ancestral tree that we now use so commonly. So what does this have to do with the electronic health record? Hopefully it has something to do with it, otherwise I'm in big trouble. here's my first hypothesis. If you take a look at the electronic health record as a technology in evolution, I think it's going to be subject to the same rules that apply for biological evolution. The second hypothesis is that the primary reason the electronic health record has been so difficult for people to adapt to is that the environment within which it was evolving was inappropriate and insufficient to the task. The EMR was originally designed in what environment? What was that niche that I think was so fundamentally inappropriate and caused a lot of our current problems? The 15-inch computer monitor. Now, can you really talk about a computer monitor representing an ecological niche? Well, from an adoption standpoint, the electronic health record is only as functional as the data can... Boy, that's weird. I think we have a buggy device. It's doing strange things. See if I can do this manually. Sorry about that. I'll do this manually. So I think that the EHR is only as functional as it can be displayed. If you have a monitor that's off, the EHR is essentially non-functional. And as we'll see, the 15-inch display monitor causes all sorts of problems. It's my contention that it was unreasonable and inappropriate to think that a 15-inch monitor could support an acceptable workflow inside the hospital. So if an EMR obeys some of the same rules which apply to adaptive radiation, as new environments become available, the EMR is going to have to change. It's going to have to change. You can't take a 15-inch design EMR and move it to a 30-inch monitor or a 4-inch phone or an 8-inch iPad in order to be successful. And if the EMR doesn't change and evolve, then that vendor's EMR is going to go extinct. Adaptive radiation tells us that the environment forces change, forces adaptation, and the resulting development of new traits that the organism or the EHR can then use to exploit the new resources, the new applications that the computing environment has. So in the context of an EMR, this tells us that as these new environments become available, it's going to have to change. The original EMR will sort of cease to exist as it absorbs new functionality that are available on these smaller, more nimble platforms, or it takes advantage of the larger workspace of a 30-inch monitor. Now, one of my thoughts here is that evolution applies to the EHR. So let's take a step back and take a look at the work of Henry Petrosky. Henry Petrosky is an interesting guy. He's a professor of civil engineering and history at Duke, and he's written a number of books, 3 of which I've listed here. To Engineer is Human, The Role of Failure in Successful Design, which is in 1985. The Pencil, A History of Design and Circumstance in 1990. Surprisingly, it is a book about the design and history of the pencil. I found it a fascinating read. What can I tell you? The Evolution of Useful Things in 1992. What I've done is I've taken some of his thoughts and concepts and adapted them for the EHR. The first is the golden rule of design. The form of made things, like an EHR, is always subject to change in response to the real or perceived shortcomings, their failures to function properly, i.e., it is the shortcomings and failures that force products to change. And here we have a square wheel. Oh no, that's just the prototype. So hopefully things do change. No made thing is perfect. Therefore, no EMR is perfect. The future perfect can only be a tense. It can't be a thing. No vendor is going to come out of the box and show you a perfected EMR. Can't possibly exist. Therefore, all EMR designs are to some degree failures because all designs make compromises, and compromise is a kind of failure. So all EMRs are going to be flawed. and it's these flaws that are more immediate than rightness. It's departures from the norm which stand out in our minds rather than the norm itself. Doctors and nurses are expert at using this tool. They will find the smallest flaw. And every time they find a flaw, a change request is going to come into the IT shop to make a change. And a service request is going to go into the vendor to make a change. This is very problematic, actually. This causes a lot of issues. But it's these flaws that drive evolution, the compromises. Now, it's your flaws that make you perfect. Now, people may say that about beauty, but I don't think anybody ever said that about an EMR. All they say is, it doesn't work, it's bad, something's got to change. Okay, to summarize, an EMR is a made thing. And all made things are imperfect. The EMR is changing over time in response to external stimuli, and in response to its perceived flaws. As a result, it's a technology in evolution, and the pace of change is extraordinary, particularly when you compare it to the old paper record. And we'll come back to some of the implications of that at the end of my talk. But what does it take for an EMR to be successful? What purpose does the EMR fundamentally serve? What is the EMR evolving into? These aren't trivial questions, and since different audience members may be coming at this from different points of view, whether you're finance or administrative or HIM or clinical, I'm going to take the speaker's prerogative and just put on my physician blinders and say that the purpose of the EMR is fundamentally to tell two stories about the patient. The first is the patient's health and wellness story. The second is their story of illness and response to treatment. Fundamentally, that's what I'm looking at from an EMR. As a clinician, then, why do I need these stories? Why do I need the EMR? Because that tells me if you know what the user needs, that's how you determine what kind of functionality the EMR is going to have as it evolves. Why are these stories important? So I like history, and this time we're going to go back not to the 1800s, we're going to go back to 400 BCE. We're going to go back to the Hippocratic school. I think you all are familiar with primum non nocere, first do no harm, which is known as the Hippocratic Oath. Actually, the first aphorism of Hippocrates is known as the Ars longa vita brevis. And I'll read it first and then explain what it's interpreted to mean. Art is long, life short, opportunity fleeting, experiment dangerous, judgment difficult. 400 BCE, they realized that the art of medicine is enormous and life is too short to learn all of it. Think about that in our context with the rapid increase in medical knowledge year by year. Opportunity to treat the patient is fleeting, and experiment at the time of treatment is dangerous. Judgment is difficult. Nothing has changed since 400 BCE. This is the issue in a nutshell. The EMR is there to provide me with a tool to improve my ability to make judgment so that I'm not experimenting during my fleeting opportunity to treat the patient. 400 BCE. Judgment requires that I have access to information and situational awareness. And situational awareness is really context. It's understanding the activities of all of the other folks that are interacting with the patient that provides a context for my activity. It also tells me how the patient has responded to prior treatments that may or may not be the same or different than what I'm planning. I'll give you a good example. My wife is an infection preventionist at our hospital system. She got a phone call actually yesterday from a nurse on the floor saying that they had a patient who had 3 AFBs, acid-fast bacteria stains, that were negative, and could the patient come out of airborne isolation? Ordinarily, the answer is yes. She happened to be walking into our house. She logged into the system, pulled up the medical record, looked up the ID consultant's note, and happened to see that he said that even if the patient had 3 negative AFB, he wanted the patient kept in isolation because he thought it was highly probable the patient did have TB. This was an example where, had she not had that context, the judgment would have been wrong. So the goal here is bringing context and information at the time of judgment. But there's different environments that as a clinician you can find yourself in, and these different environments have different workflows associated with them. So whether you're using small devices like a handset or a tablet or small, medium, or double screen monitor setup, the workflows associated with these are going to be necessarily different. And whenever you have divergent workflows, you're going to have divergent needs from a clinician standpoint, and you have to come up with divergent solutions. Again, you don't want to take your EMR, stick it on Citrix, and just put Citrix on your tablet. It's not going to cut it. That's extinction. That's not evolution. So we're going to start by taking a look at the bigger side of this equation. We'll come back to mobility and the smaller devices in a moment. This, I think, for any of you that are clinicians, doctors, nurses, etc., that have worked in a hospital, this was a very typical environment before full-blown EHR. And what you have here is you have a monitor for results. You've got your paper chart that in this case is open to orders, could be open to progress notes. You could have orders and progress notes side by side. You have the typical trifold with the patient's vital signs, I's and O's, diabetes, neurological assessment. All of this information is exposed. It is not random chance that this is the way so many of us did our work. This was a workflow that evolved over time. Let's take a look at what's involved here. Physician workflow is not linear. We don't walk in, look at the chart, see the patient, write a note, and go on. Physician workflow is nonlinear. We are interrupted and exception-driven. We are ad hoc in the way we approach patients. We walk in, we see a lab, we want to write an order, we look at the note, we see what our partner did the day before, we go see the patient, we come back, we see another lab, we respond to it, we write more orders. We're back and forth, we're using all different parts of the chart. But this was the environment. The environment was, on paper, if you took a look at what I had out there, between the paper forms and the monitor, I had 350 square inches of data displayed for me to do that work. 350 square inches of data for me to sit down and do an inpatient visit. That's 3 monitors worth. That's a 14, a 15, and an 18-inch monitor in landscape and portrait mode. But what did we do when we put in an EMR? We said, okay, here's your desktop, your monitor, your paper chart, your vital signs. We're going to throw your paper chart on the monitor. We're going to throw your vital signs form on the monitor. We're going to shrink it all down. And we're going to layer one on top of the other. So you can no longer see all that information. You're going to get this one little itty-bitty window on the electronic record. Is anybody aware of any studies that took a look at this and said that, yep, this was going to be an acceptable way to do work? There wasn't any. This was fundamentally a flaw. There's no possible way that as a physician you can take 350 square inches of data that I need to do my work and now put it on a monitor and make me scroll and open and close windows and have me be satisfied. Not only that, this is dangerous. So I've already suggested that this design, which was originally made for a 15-inch monitor, would be inappropriate and inefficient for a 30-inch monitor. We're going to take a look at that. The 30-inch monitor gives us new resources, new possibilities that the designers of the original EMR couldn't possibly have imagined. And therefore, while some EMRs may not change, those which adapt and evolve will be more successful in the long run. What functionality of the EMR has to change? Well, you need to know your user, right? It's the old adage, you don't want an engineer designing the EMR, you want clinicians designing the EMR with engineers enabling it. The National Institute of Standards and Technology published a white paper. It's an interagency report that summarizes the use of user-centered design in the development of the electronic health record. User-centered design involves fundamentally understanding the user's needs, workflows, and environment, designing the user interface from known behavioral principles and familiar user interface models, understanding how that electronic health record is meant to fit within the practice or system, and where that EHR is going to be used, how often and by whom. In short, it's not EHR know thyself, it's EHR know thy user. In my case, I look at it as what I call scenario-based interaction. When I'm doing design, who is the user? Why is the user doing what they're doing? What questions are they trying to answer? And in response, what actions are they likely to take? Provide that information to them in a manner which improves comprehension, and there's different ways that you can provide information, and then integrate the actions without losing context. A good example would be I'm going to prescribe antibiotics. In context is with the BUN and creatinine and the culture results and the prior antibiotic experience. Out of context is just an order sentence for ordering an antibiotic, right? Other things that you can do. Don't hide the data. One of the problems with the 15-inch monitor is it hides too much. Data is hidden. Questions come up. Where is it? I don't know. I can't find it. Scrolling. Scrolling is nuts, particularly in electronic health record, because hidden data makes analysis difficult, it interrupts the user, and it leads to error. You forget that something is scrolled off the page. You forget there's more information at the bottom of the screen that you didn't look like. You forget there's information hidden behind a column of data that really should be exposed so that you could see it. Minimize your user's eye movement. If you co-locate the data elements when they're required for decision making, you'll make better decisions. You'll be more efficient. Don't make me look for the antibiotic over here, the culture results at the bottom right, the BUN and creatinine on the top left, interspersed with information that's irrelevant to the decision I'm making. Put all the information that I need to make my decision in one place in a logical format that enables me to make my decisions and doesn't distract me. So a 20-inch monitor, which is pretty common in the hospitals today, it's roughly 17 by 11. It varies depending on aspect ratios and manufacturer. And that's basically two 8.5 by 11 sheets of paper side by side. In my view, when I was mocking this up for a talk I gave 2 years ago, I live in the ICU. I want that flow sheet data exposed. I would like to see radiology images there that I can access immediately. Don't hide them behind another window. Have the thumbnails out there. Have the waveforms there so I don't have to get up, walk down the hallway to find out where the central monitoring station is. Show me what's going on the waveforms. Show me data, and allow me to do my order entry and progress notes all at the same time. This would be sort of my ideal workstation. Well, if you take a 30-inch widescreen monitor and you layer this on top of it, this is what you get. And so the mock-up that I made was the following. Okay, I just cut and pasted, you know, we've got 3 8.5, 11 pages at the bottom, which is my progress notes, my orders, my results review, thumbnails on all of the x-rays, my waveforms, and my vital signs. I presented this at a Cerner conference, and it caused a bit of a stir because 30-inch monitors aren't usual in the hospital. And at the end of the talk, one of the Cerner folks that was there stood up and said, "So if we designed something like this, how many of you would be interested?" And everybody stood up. They said, "Oh." So I got introduced to some of the design team and have been working with them for the past year and a half. I'm going to show you some early screenshots. This is actually the stuff that we were working on is now generally available. So initially we're trying to say, okay, gosh, I would like to have my flow sheet information, you know, available all the time. And then we're going to have available down here my clinical information and my thumbnails of different images that are related to the data that's out here, and then have everything, you know, nicely correlated between, you know, on the times, the I's and O's, all of that. This you can't read. This is a view of respiratory care, and as opposed to some of the typical designs, this is organized so that, for example, here's all the ventilator settings, here's the blood gases, and here's what we monitor to see if the patient's ready to be weaned. This would be married in the actual design with the x-rays for this patient, the orders for respiratory care, and the progress note all matched together on one 30-inch screen. So we're working on building that vision using a 30-inch monitor. On a 15-inch monitor, you could never think about even entertaining this kind of idea of having orders, progress notes, lab data, and images all available at the same time. This is a workflow that doesn't take a lot of education because you don't have to teach people where are the x-rays hidden, how do I get to them, where is this piece of data hidden. It's not. You want to expose as much data as possible, do as little clicking as possible. The more efficient the design is, less education. Right? In the paper world, how much education did I have to get from medical records to come in and learn how to use a medical record, whether I was at UCSD or Palomar or Northwestern or University of Michigan or wherever I've been? None. I have to have 8 hours of training to use an EHR. I think if these are done correctly, that shrinks to an hour or two with the right kind of design. So that's large screen. I think the EHR is going to have to evolve to take advantage of these newer screens. I think there's just too much opportunity for improvements in workflow and patient care and satisfaction from both the doctors and the nurses. So let's take a little bit of a look at mobility, a physician's perspective. A mobile physician within a hospital is best served by what suite of devices? A mobile physician outside the hospital, but with an inpatient focus, which devices? Different than if I'm in the office, if I'm at home. What happens if I'm at the ballpark, I'm at the sailing? What kind of devices do I have with me? What kind of questions am I going to be asking or answering? For example, when I'm at home or I'm out at a ballpark, I'm not admitting an ICU patient. I'm not doing an ICU consult, right? I'm answering a page. And so the information that I need is fundamentally different than when I'm in the hospital and I'm admitting a patient. So you have to understand the workflows. So let's take a step here and take a look at what the current usage of mobile devices are among the physician community. Healthcare Without Bounds is a white paper that came out from Spyglass Consulting in February. For this, 100 physicians were interviewed, roughly 50% inpatient-based, 50% based in a clinic. I'm going to give you some high-level, the details are available within the report. First question is, what's the primary computing device used by physicians to access clinical data? Okay, 83% it's desktop. 83% of these physicians are accessing clinical information on desktops, 12% on laptop, which is essentially the same thing. So 95% of data is primarily being looked at through traditional laptops and cabled computers, with tablets and none comprising the other 5%. Are physicians using laptops? Yeah, 73% are. And they're primarily using it for email, reference, and internet, as well as accessing the hospital. So the standard things that you would expect out of a cabled computer: email, reference, internet, hospital-based applications, less so in the office. When are doctors using mobile devices? Well, when they're traveling, business travel, vacation, or when they're at affiliated hospitals. They're not tending to use mobile devices when they're at their primary place of practice. Are physicians using tablet computers? Yep, 68% are, 32% aren't. What are they using tablets for? Well, first of all, most are using Apple, right? 94% in this survey of the tablets being used were Apple, 6% were Android. And they're using this for personal content, internet and communications. Very little use, relatively speaking, for EMR, and really reference didn't even show up as a response. So you've got personal content, internet, communications, and about 20%. So 20% of 4% are using it for hospital EMR. The limitations being data entry and lack of applications. Shrinking a large screen into a small screen is fundamentally difficult. It's problematic. There are niche uses for tablets, but they're too small to be a desktop replacement. They're too big to carry with you when you go to the ball game or a restaurant. And so when they were asked, is an Apple iPad ready to transform patient care delivery? The answer was 80% said no. 20% yes. Now, how about the use of smartphones to communicate with colleagues and patients? 98% of these physicians had smartphones. And they're using Apple iPhone about 70%, Android 10%, BlackBerry 20%. However, physicians are not typical of the rest of the world, where Android, as of third quarter of last year, has 50% of the market, and Apple has 15%. Apple's flat and falling. Android had doubled, and BlackBerry, well, we all know, unfortunately, what's happened to BlackBerry. It's fallen off the face of the planet. And how are physicians using smartphones? More applications and uses for smartphones than any other device in the survey: communications, scheduling, personal information management, internet, location-based services, reference information, but very few using it for hospital applications. Smidge for hospital EMR, and a small amount for lab results, and about 5% for e-prescribing. And the problems, as expected, are related to screen size, lack of applications, and the difficulty doing data entry. So I'm going to show you what we ended up doing to design our own mobile health applications, our own mobile health platform. MIA is a mobile health platform that we originally designed 2 years ago, and as I said, is being commercially licensed as of probably later this afternoon. It was designed to be agnostic to the back-end system. Cerner develops for Cerner, Epic develops for Epic, Allscripts develops for Allscripts. We wanted to develop a mobile device, a mobile application that would be independent of the back-end system, that would reach across organizational boundaries, that would be integrated with sort of next-generation physiologic monitoring for waveforms, would take full advantage of the operating system. There's two ways that you can design mobile applications. You can design them for the web, in which case you get a shrunk-down web view, or you can design it for the operating system itself. And when you design for the operating system, you then can take full advantage of the device, teleconferencing, basic telephony. You can integrate all of that within the product itself. You get a much better user interface. This is our sort of cartoon view of the U.S. non-healthcare system. We're a healthcare sort of non-system, and as we all know, you've got all sorts of different silos of information. You've got your universities, diagnostic imaging centers, long-term care, academic, medical supplier, physicians, reference labs. Everybody's got their own source of information. We wanted something that would provide a patient-centric view, would cross organizational boundaries, and wouldn't give you a siloed view of the patient's record, because the goal, again, is to enable the clinician to have increased judgment and context at the time they need it. We also have been doing work with Sotera. Sotera is one of a number of companies that is being developed now that has wireless monitoring capabilities for ambulatory patients. I think that that kind of functionality is critical to improving safety in hospitals. You may not be aware of this, but 50% of deaths in hospitals, not no-code patients, not DNR patients, 50% of the unexpected deaths take place outside of the monitored environment, take place outside of the ICU. When you get into your car, what's the first thing you do? You put on your safety belt, right? There is no seat belt in the hospital for our unmonitored patients. And the best thing that we do today is we throw a telemonitor on them, and tele's a lagging indicator. By the time their heart rate starts to go bad, you've missed the boat. You missed the 8 hours of critical time when you could have intervened, the failure to rescue issue. Sotera, which is a startup, just got their first FDA license, can do things like non-invasive vital signs, non-invasive blood pressure. continuous non-invasive blood pressure without a catheter, without a cuff. Respirations, oxygen saturations, heart rate, EKG, skin temperature, motion. It's a voice over IP phone. You can connect it directly into your nurse call system. You could have the patient and the nurse essentially always in communication. Right now, from an FDA standpoint, they only have standalone blood pressure license. The rest of this is in the future. But the future vision is of this kind of monitoring ubiquitously throughout all the hospitals. So we've partnered with Sotera to bring in their waveforms into our device. So currently, and I'll show you some examples, we bring in the patient's ADT information, their lists, their diagnoses, handoff notes, care team members with integrated teleconferencing, all the usual things you'd expect from an electronic health record. Then we've merged that with functionality like secure messaging, right? If you don't take advantage of the new environment, you're just bringing the old EMR to a smaller platform. Right now, if I get a page for the ICU, I want it to come up on my phone, bringing the record with it. If you're going to call me and tell me that potassium is 6, let me see that in the context of the patient, their medications, their allergies, their BUN and creatinine, and their current medications. Don't just page me and tell me the potassium is 6. That's what the ultimate goal is here. We've also integrated this with NewHIN. So we can, on the fly, generate a CCD document from NewHIN using NewHIN direct protocols and or receive NewHIN direct information, CCD information. So it becomes a mobile gateway onto the nationwide health information network. So it gives us real-time access to physiologic status as well as the electronic health information from a single user interface. Doesn't make a difference whether your back end is the Vista VA system or Cerner or NextGen. The front end system to the user looks exactly the same, and it operates just like you would expect any touchscreen device to use. And it doesn't make a difference what device you use. We developed it initially for Android. We now have it working on Apple. Android's just an easier area to develop in. So this is an example of sort of what a typical screen could look like, where you have your patient lists. You have location services. You've got a GPS-enabled device. Depending on what facility you're at, those are the lists that it's going to bring up initially. Integrated with your vital signs monitoring, this is a different kind of opening view. And these are all active screens, so you can tap on the waveforms. Bring in your imaging. So we just convert the images to JPEG 2000s and bring those in. Not meant to be diagnostic, but give you more information if you have a question. And integrate that with the messaging as well. Bring in all the documentations that folks may need. So, I mean, that's what 3 of us did at our local community hospital. Well, we happen to have a really superb programmer, a software engineer who's, a wizard. But it shows you where the technology is going to go. Okay? If you think that having your Citrix view on a tablet is sufficient, you're going to get leapfrogged by the local community hospital down the street. Okay? That's sort of my message there. So, the Galapagos. Let me just get back to where we're at here. All right, to recap. If you recall the voyage of the Beagle, it led Darwin to collect birds, and those birds revealed important new insights on how adaptive radiation changed the birds, evolutionary biology, and the development of species, and the evolution of diversity. We learned from Professor Petrosky's work that the EHR is a technology that by necessity is in evolution, and I think responds in the same way that the birds did. It's going to have to adapt and change. And whereas Darwin's finches existed in various environments in the Galapagos Islands, we've identified new environments that the EMR is existing in. Tablets, smartphones, large screen monitors. In the next couple of years, we'll start to see flexible monitoring screens. You'll start to see small devices that unfold to big screens. These are new resources. These are like new islands popping up that the EMR can now populate. Divergent environments, new applications, new opportunities, new resources, new challenges. And we've seen what happens if you don't respond well to challenge. You, like the Osborne, become extinct, right? I don't think anybody here has an Osborne computer anymore. We're going to have a lineage that's going to evolve, and it's going to take advantage. This one may be on its way to extinction. I'm not sure. Anybody here from mobile? Anyway, so as new devices come up, there's going to be forced change. That takes a nimble vendor, a vendor who doesn't mind changing. A talk on evolution, a talk like this would not be any good if we didn't make some predictions. And so I'm going to make some general predictions. Winners, i.e. vendor EHRs, will, if they're going to win, evolve to take advantage of these new environments. They're not going to stand pat with their current old solutions. They're going to have to evolve to match workflow expectations. If I'm a physician and I'm mobile and I want something on my phone, you've got to match what my needs are as a user, not what you think the information is. You've got to engage the user community. You've got to redesign the information to be displayed in a way that meets my needs. And you've got to take advantage of the new resources and create new solutions. Don't just put your EMR on my phone, put it on my phone, but utilize GPS and text and other things that a phone has to bring new functionality to the EMR. You'll come up with new solutions, new opportunities, new workflows, things that we couldn't have even conceived of 10 years ago. In conclusion, the EHR is in a state of evolutionary design. It is a cornerstone tool for the care of our patients. It is changing rapidly in response to flaws, in response to changes in the regulatory environment, in response to the rapidly changing computing environment. This constant change leads to chaos that I think all of you have seen inside the clinical environments. You don't put in an EMR, put in your devices, and stop, and let them use it for 5 years before making the next change, right? It's constant change. And that's what's making it so difficult currently inside the hospitals, right? There's no chance for them to get used to the current functionality. They're already starting on new functionality. There's new expectations on charting, and it's truly chaos. It becomes really unsatisfactory, and without the proper safeguards, potentially unsafe. We go back to Hippocrates, primum non nocere, first do no harm. And so this chaotic clinical environment is a consequence of all this neat stuff that we were talking about. The new computing platforms do represent novel environments and great opportunities, as long as the potential for harm is recognized. If users are engaged in the design, I think there's great promise. And I think that as the EMR evolves, I think 10 years from now, we're going to have an environment within hospitals that in no way reflects, the past 10 years of difficulty. So with that, I'd like to say thank you again. Thank you for letting me present sort of my thoughts on both small screen and large screen development, and I appreciate being here. Thank you very much.
We do have time for questions. So questions, anyone? Okay,
I like
we got
my
one.
questions.
Okay.
Awesome presentation, Ben. I'm Dale Sanders.
Thank you.
Can you go into any more detail about what you're doing with Cerner without violating any kind of...
Oh yeah, no, the Cerner stuff is all public and generally released. I mean, it's not hidden. Cerner has a functionality called MPage, which allows you to do some more custom design at a local level instead of waiting for the host corporation to make changes. And just working with one of their design teams, we took the 30-inch monitor at high resolution and said, gosh, what could we do with it? We wanted to redesign the user interface and provide as much information that was actionable. How would you redesign an EMR given that environment? And we started that, and I was sort of in the right place at the right time to get that going. But we're working with a number of other university medical centers around the country, and that's an ongoing project. And
user-centric. Are you still involving him in that activity? And
So the user-centered folks from Cerner are the ones who are driving the, if you will, the UCD from Cerner's side, and then they have the physician groups from all over the country with whom they're working to drive out, what the final look and feel is.
thank you very much.
Yeah. And that's no means by way of plug for Cerner. I will let you know that our hospital, by the way, is also a Kaiser shop. So I have Kaiser physicians that are used to using Epic at the main hospital. They use Cerner with us, and I know that Epic is doing the same thing. I know there's a group of Kaiser physicians that are working with Epic to help expand their EMR as well onto a larger screen.
So, Sharif Tarman from Chalk/UCI/just around.
Yeah.
I have some of my desktop people here, and so my suggestion or my question would be, at your institution, are you buying anything less than 30-inch monitors going forward? And would you make that endorsement for our guys so that they hear it? I mean, is it worthwhile even investing in anything less than that? I think most of ours are 24-inch at
Right.
this point.
I think 24 right now is sort of the sweet spot. I think that's what everybody is putting in. When we open our new hospital, it's going to have 24-inch monitors, essentially. We may start to put some 30 inches around. It depends on, I'm doing a lot of design work. It's not like we're implementing everything I've designed. It's really kind of sad because I do a lot of design work and I see other institutions putting in place before we do. We're a public hospital district. We're opening a brand new medical center complex. We have zero free capital. And so I'm dependent on external funding and the largesse of companies like Cerner to work with me. We design it, doesn't necessarily mean we're putting it in place, unfortunately. If it was up to me, in the ICUs, I would put in 30-inch monitors. I don't know who your vendor is here, but I would look towards large screens if I was in the ICU. I don't think you'll need it outside of the ICU. I think there's less utility. But Cerner's moving all towards the M-page thought, and the more screen desktop you have, the more widgets you can have.
Any other questions? Oh, here we go.
Who's first?
I'll go ahead, I'm sorry.
Okay. Very nice talk, and thank you for that. The mobile device, are you also able to go ahead right there and put in orders and do actions besides just the viewing?
Yeah, so that's an excellent question. Not at this time. We're building the order entry capability right now. Yeah, the initial live pilot against live data is coming up shortly, and it's really to verify.